All right, we can go ahead and kick it off. My name is Casey Mcpherson. I am the manager of the Alliance for Patient Access's Texas State Chapter. Again, thank you everyone for joining to hear a little bit more about some access barriers in the headache and migraine space. I'm excited to be joined by some fantastic panelists that we will get to here shortly. But first, I'm going to provide a brief overview of AFPA. So the Alliance for Patient Access, if my slides will cooperate with me here. The Alliance for Patient Access is a national network of healthcare professionals dedicating to promoting the benefits of patient-centered healthcare. So we do this through a number of ways, but first and foremost, we like to educate clinicians on the issues and kind of empower them to be advocates for both themselves and their patients and allow them to engage with and inform policymakers. So a little bit of background on AFPA. We were founded in 2006 by Dr. David Charles and Brian Kennedy. Again, we're a group of clinicians that are advocating for patient access. We have hundreds of healthcare providers, over a dozen specialties in all 50 states. Most of our providers have a sort of a policy aspect to them. We're also active in a number of societies and professional organizations, and we are a 501c4 nonprofit. So patient-centered care is kind of at the heart of our mission. A little bit more about what that is we really value a strong clinician-patient relationship. We want to make sure that patients are empowered and engaged in their shared decision-making. We want to make sure that they're active participants in their own healthcare. We also recognize that patients don't benefit from a one-size-fits-all approach. We want to make sure that they are able to have care that is catered to them and ensures that they are receiving the kind of care they need in the place that they need it. We support, policies across the board that just improve access for patients, and that's kind of the theme of the webinar that we're having today. And we recognize the value of getting it right and making sure that patients have the treatment that they need when they need it. So what does our clinician advocacy look like? We do this through a number of different ways. Virtual events like the one you're joining today, in-person events, obviously, in light of COVID, that's been a little bit more difficult, but we're excited to be transitioning towards a few more of those in-person events in the future. We do a number of educational materials. You'll see on the screen, there's an infographic on prior authorization. We have videos that you can find online. We also write papers, more detailed policy papers. For example, there's one on the screen about non-medical switching, another thing that you'll hear a little bit more about today. And then we also have a blog. And so these blogs will cover a number of topics that we'll kind of meet with our clinicians and our members to hear a little bit more about what they're seeing. And we can then, in turn, pull together something quick and short, but a very good explainer on the issue. So I mentioned that we have a number of working groups. There's actually 11 of them. The one you see kind of highlighted in the middle there is the Headache and Migraine Disease Working Group. Dr. George Nissan, who will be joining us as a panelist in a little bit, is a member of that group. But these working groups span a number of different disease states, and so they kind of allow us to engage with our clinicians on issues that they're seeing in their particular disease state and cater our advocacy towards clinicians in that space. And then lastly, we also have a number of state chapters. So California, Florida, Iowa, and then obviously Texas. These state chapters allow us to be a little bit more engaged. We have teams on the ground that kind of plug us in a little bit to the legislative happenings, and we're able to work with our clinicians to have a more active role in the legislative activity in those states. And so obviously Texas is one of those states, so we're excited to have everyone here today. And with that, I will pass it over to the Executive Director of the Headache and Migraine Policy Forum, Lindsay Vidnieks.
That's very good. Thank you, Casey. Nice to meet everyone. I'm Lindsay Vidnieks. I'm the Executive Director of the Headache and Migraine Policy Forum. I want to thank AFPA for co-hosting this event and to our audience of state legislators and staff who are working to help Texans receive optimal care. We also have two wonderful advocates with us today and some advocate groups on the line. We appreciate your time and attention. So next slide, let's do a quick overview of Hmpf. We are a coalition group of 24 members in the community that really focuses on policy and access for patients. So you'll see this photo here is an example of the Capitol Hill Policy Forum that we held during Headache on the Hill, including members of the Texas delegation. So migraine advocates are extremely passionate, engaged, and involved. And so we help them navigate access barrier issues both on a state and federal level. Next slide. And these are some of our members. So you might be familiar with some of these groups, some that have Texas state chapters, but you'll notice that it's a diverse sort of coalition, right? It's veterans, it's women's health, it's folks who care about pain issues. All of these intersect with migraine and as a disease. Next slide. So Dr. Nissan's going to speak a little later, but I wanted to do sort of a level set for the audience in case, folks are unaware of just how systemic migraine is and how, truly it affects about 12% of your constituents. And so it is the second most disabling disease in the world, according to the WHO. And importantly, migraine patients are the fourth highest users of the ER. So it's a very expensive disease in terms of a medical benefit, and painful because folks are ending up in the ER at high numbers, impacting 40 million Americans. If you want to do the math, that's about 3.5 million Texans. And it also is very prevalent in women. About 75% of migraine patients are women, and more than 30% of women will have a migraine attack. But we also want to make sure that we note that veterans have a disproportionately high number of migraine attacks and headache disorders. And so there is that stigma as an invisible disease, and especially for veterans who may experience the warrior effect and not want to talk about the fact that they think it's just a headache, but it can be quite disabling for them. Next slide. And so there's an impact on the patient. There's also a greater impact on society and the workforce. This hurts Texan patients. It also hurts Texan employers. As noted on here, direct and indirect costs of the disease cost about $78 billion a year nationwide. And as I mentioned, because it largely affects women, it's a women's workforce issue and retention and whether folks can stay in the workforce. And so as you're thinking about your constituents and how they're impacted, it's certainly a women's issue, it's a women's health issue, it's an employer issue. Next slide. So that's a very quick overview of the disease. And you've heard a little bit about how difficult it is to sort of diagnose as a spectrum disease. It's different for everyone. It's a very heterogeneous patient population. But it's also incredibly difficult to treat in terms of access barriers. So that's what we're really trying to focus on today. Next slide. We're going to talk a bit about a few of those. I want to start with non-medical switching. For migraine patients, non-medical switching affects all disease states, but specifically for migraine patients, that's where an insurance company may switch a stable patient, a patient that has been on perhaps a neurotoxin that is working for them, and then switch a patient to a new treatment, not because it's medically necessary, but because it may save them a few dollars on the bottom line. And so, for migraine clinicians, botulinum toxins are similar, but they're not all the same. And so they may have different dosing, formulation. Clinicians might prefer one over the other. So when the switch occurs, this may disrupt the patient's treatment, requiring the physician to use a drug they're just unfamiliar with, which could increase medical errors. Next slide. And so, can we go back one? I just wanted to mention, a lot of states have started drafting non-medical switching legislation. Currently, there are 3 states that have introduced bills. That would be California, Iowa, and Pennsylvania. And for some of the folks on this call, you may know that Texas introduced non-medical switching legislation in 2021 by Senator Lambert and Zaffarini. But unfortunately, that bill didn't pass. So the community is grateful for those efforts and hope that there'll be a renewed interest in that. Next slide. Combination therapy. So as I mentioned, the disease is very heterogeneous. Patients have long used treatments in combination, but insurers are finding ways to deem that combination therapy investigational, even where it's been proven or the FDA has cleared that use. And so, prior authorization occurs when the patient or clinician has to receive permission from the insurer to prescribe what's medically necessary. But the delays for migraine patients can be severe. This is a disease that's progressive. Attacks can chronify. So that's for the patient. For clinicians, as folks may know, this increases staff resources, so they have additional paperwork. And so that's a challenge that's facing the community. I know in 2021, Governor Abbott signed a law that would allow physicians to receive a gold card if they receive a track record of enough previous approvals from insurance. So we think that's a positive development. Next slide. Step therapy. So, that is a fail first practice where insurers may require patients to try and fail several other medications before they can access the treatment prescribed by their clinician. Within migraine disease, this can mean for infused therapy, for example, maybe 6 or 8 required steps. And so, as you can imagine, as a migraine patient's waiting close to maybe 10 months to receive the actual treatment their clinician prescribed, their attacks are worsening, their pain is increased, they're losing work days, there's an impact on the family. And then this is also, of course, very expensive because if they're ending up in the ER, in many cases, they're not seeing a headache specialist, they're being prescribed an opioid. So there's a big connection here between the results of some of this onerous utilization management and the expense to the patient and to the system. And so an update on state legislation. There's a lot of states, probably about half, that have introduced bills on step therapy. Kentucky was the latest state to do that just this past year. And we're grateful that, Texas has a step therapy law in the books and has that clear exception criteria and enumerated timeline for appeals. Next slide. Potential prescriber restrictions. So this is something we wanted to raise because, migraine is a complicated disease. It needs to be treated by folks who are specialists, but there is a nationwide shortage of headache specialists. So there are times when insurers have required patients be seen by a UCNS certified specialist. We are thrilled that we have one of those on the webinar today. Dr. Nissan is a certified headache specialist, but there are only 41 of those folks in Texas, where there are 3.5 million patients to treat. And so where an insurer may be very specific about the type of clinician that would have to treat a patient, that sometimes means excessive wait times for patients to get an appointment, leading to further attacks, et cetera. Next slide. An additional point we wanted to raise is that, as states are considering how to expand or navigate telehealth in a current COVID or post-COVID environment, for the migraine community, because there are no real biomarkers per se, it's very much about the doctor-patient relationship. We want to make sure that there is a balanced approach to telehealth. So there's not a thumb on the scale saying that a telehealth visit is advised or reimbursed at a greater level than an in-person visit. And so this is a complicated disease. It really requires a balanced approach to care, and in-person care is still very essential. So actually, I think that we can skip this slide. We're going to move on to our panel questions. With that level set in mind, and we can just move to the panel. A theme that I think we want to introduce in our discussion today before I get to our panelists is the treatment's a real journey, right? So patients, as I mentioned, develop a relationship with their doctor. They learn what works, what doesn't. And one of the most significant issues that patients end up facing after getting that final sort of correct diagnosis is accessing medications to treat their disease. So thank you for listening to a level set. More importantly, I want to move to talking about the real world evidence and how this all works. So we are lucky to be joined by two fantastic panelists. I'd like to first introduce Leslie Wood, who is a chronic migraine patient who found herself an unexpected mother of 3 after her husband passed away. She works as a social worker for teens in crisis, and she is passionate about helping policymakers understand the importance of treatment access. So thank you, Leslie, for being here. And then we're also joined by Dr. George Nissan of the North Texas Institute of Neurology and Headache. Dr. Nissan has been treating migraine patients since 2003 and received a UCNS certification in headache medicine in 2008. He joined the North Texas Institute of Neurology and Headache in 2017 and has continued to practice patient-centered care with a goal of a unique individualized treatment approach for each patient. He also serves as a member of the Alliance for Patient Access Neurological Disease Working Group and Headache and Migraine Working Group. And he also happens to be the constituent of State Senator Nathan Johnson and State Representative Anna Marie Ramos, who thank you for being here. So welcome to both of you. We're just so excited to be joined by our audience of Texas state legislators and their staff. These are problem solvers, as I mentioned, who are interested to hear your perspectives. So let's get started. You heard, I guess this is going to be a question for Dr. Nissan first. We talked earlier about non-medical switching, and a good example here in Texas is that we understand that CVS Caremark recently changed its formularies with very little notice and switched patients from a stable therapy to a new one. And so that can be a problem. Can you talk to us a little bit about how non-medical switching typically looks like for a headache or migraine patient?
Thank you for having both me and Leslie on the forum today. But yeah, the non-medical switching has become very pervasive in recent years. And this year was a big blow with what you were talking about, Lindsay, about the CVS Caremark. So what happens in non-medical switching is that the pharmacy benefit managers, or PBMs, are the middlemen between the insurance companies and the patient. Basically will go and contract out with let's say they're with a large company like Amgen, one of the biopharma companies, wherever it is, and they'll start working in rebates and things like that. And they'll take patients off of their drug that they're currently on and say, well, this is a similar drug in the same class, but it's still going to be, so we're not saying you can't be treated on this, but we're just going to switch you to this other drug in the same class. So now the CGRP antibodies, what Lindsay's referring to, so calcitonin gene-related peptide blockers, are pretty much revolutionary in the migraine world. They're monoclonal antibodies. And when we think about monoclonal antibodies in the COVID-19 world, this is actually very big in neurology too, in multiple sclerosis, epilepsy, and now in migraine. And May of 2018, Amgen came out with the first monoclonal antibody ever made for migraine prevention, which was Aimovig. And so that got FDA approved in May 2018. Then in October and November of 2018, Teva came out with Ajovy, and then Eli Lilly came out with Emgality. So these three drugs have been pretty monumental in the headache world. And what happened was that a lot of patients have been on, a lot of my patients in North Texas have been on Aimovig since literally the first week they got FDA approved in May of 2018. So we're talking almost as of this month, it would have been 4 years. And what happened on January 1st of this year is that CVS Caremark, which covers more than 1/3 of all North Texas and actually the state of Texas, insured lives, decided that they were going to contract out with Ajovy and Emgality, and they stopped everyone. They did not allow appeals or anything on it. And they basically said, okay, we're still going to cover you. We're going to cover you on one of these other two drugs. So to give an example of what happens with it is, it's just like someone who has epilepsy. When you're stable on migraine, if you're someone, for instance, who had 20 or 30 migraine days a month, and now you're down to 1 or 2 and your life has been transformed and you're able to go to work full time. You don't miss your kids' social events. Kids are not, college kids are not missing school because of this. They're getting, good grades and things like that. It's a very transformative type of thing. And you take it away from them and you say, oh, it's okay to switch you. I'm going to switch you from drug A to drug B. Even though there's no proof that you can do that, it's all hypothetical on there. There's no studies that have shown that to be effective. And basically what happened to a lot of these patients in our practice, we have 12 providers. Basically, we had patients that were in a lot of trouble. One of them wound up in the ER because they missed their dose in January, right? Because January 1st the new fiscal year restarted for them, for their insurance companies. They started having more migraines. Some of them wound up in emergency rooms. Some of them wound up getting hospitalized because they were in chronic, prolonged cycles. They couldn't break them. And it took several months for them to get acclimated to the new drugs. So all this, when you look at what's very disheartening about this whole thing is that the drugs are exactly the same price. All three of them have retail prices between $800 to $825 a month, but it's all about the contracting issue that they did to figure out how to save money. And by doing that, they really have hurt a lot of the neurological patients that have done quite well on the drug. And so I think that was I've never seen anything like this. It's really, and we're concerned this is going to happen in the future again with more of these newer drugs.
Well, and to your point, Dr. Nissan, it's fairly arbitrary. And so what might be switched one day could then be turned around a year from now. And maybe if there could be an additional switch. And so that's a great way to segue to Leslie, because Leslie, have you had an experience of being on a newer therapy and then being switched off of it? And talk to us about, what that meant for you and what you experienced.
Sure. And it's funny, like Dr. Nissan mentioning the 2018, I was one of the first patients on Aimovig. Like my neurologist in San Antonio had considered Botox because we tried everything else and nothing was really helping with any sustainability. And so she was going to do Botox, but she said, I'm going to wait because this drug is coming. Let's give it a try. And I was one of the first ones in that trial. And it was helpful. And I moved to the area in North Texas about 2 years ago and transferred my care to Dr. Nissan from my provider in Houston. Was maintaining on the injectable medication. We switched to Ajovy. I forgot how long ago it was. And my last dose was in January of this year because I got a call back from the pharmacy saying it's not covered and they're going to require you try all these lower level of care protocols to see those fail before we can justify coverage. And I've already done that. Like I did that in San Antonio, and my provider in Houston had to present. I remember him going through that at the time, prescribing the injectable then, because like, you've done this, you've done this, you've done this.
Yes. And, and to be clear for this audience, just so you know, as Dr. Nissan mentioned, it had been 25 years really since there had been anything innovative for migraine patients. They had triptan therapy, and then there was a long period where there was nothing new. And so to his point, it's very exciting for the community when there was something to treat patients. And so to then become stable and have it working for you and then be switched is not effective. And so, I guess I want to switch a little bit to the topic of combination therapy because it's related. Studies have shown that combining some of those even older triptans with newer agents when you have an attack leads to better outcomes. The FDA has approved marketing for combination therapy, so they recognize sort of the usefulness, the safety of it when you have a migraine attack, but insurance companies are calling that experimental or investigational. So Dr. Nissan, can you talk about, what it means in your practice when you have patients who are denied the ability to use treatments in combination? And do you have an example?
Yes, very good. Tell us. Oh yeah, no, definitely. And it's so combination therapy we're describing is when you take a drug like Botox, which got FDA approved that was the first drug ever approved for chronic migraine, which are migraine sufferers that have more than 15 headache days a month for at least 3 months. So about 4% of the US population has chronic migraine. 12% have the episodic, like once in a while type migraines. So we're talking about it's a fairly pervasive. You take a room of 100 people, 4 out of every 100 general population patients will have a migraine or some form of headache 15 or more days a month, so almost daily. So Botox was very revolutionary in that respect, but there were a lot of patients who got improvement with Botox, but yet it was not still enough. And when the monoclonal antibodies came out in 2018, what we found was that the synergy between the monoclonal antibodies and the injectable the monoclonal antibodies plus Botox every 3 months. So the monoclonal antibodies were once a month injections plus the Botox every 3 months. For some patients, was life-changing, and it was very big. That was we call synergistic effect of drugs. So we basically had for the first time something other than mixing an oral medication with Botox. So it's kind of what you were saying, Lindsay, that we had the same anti-epilepsy and antidepressant drugs we were using for migraine for 25 plus years, which really for a lot of patients just didn't work. And now we had this new one for some of the more difficult to treat type of patients. And so for a while, the insurance companies were allowing combination therapy with Botox plus Aimovig, Ajovy, and Emgality, these 3 monoclonal antibody choices that we had. But then what happened was starting last year, they started denying the care, and they said, well, so we had patients around Botox for multiple years, and they said, well, guess what? We're not going to cover your Botox anymore. We'll cover your monoclonal antibodies once per month.
Pick or choose.
We're not going to pay for your Botox. Yeah, we're not going to cover both. So these poor patients were left in limbo because here they were If you think about their situation where they might be down from 25 migraine days a month to 3 or 4 or 5, and they have their lives back and everything, all of a sudden you're telling them, oh, by the way, we're not going to give you your Botox anymore because your doctor puts you on this monoclonal antibody.
Well, and to your point, there's all these hidden costs of not being effectively treated, right? So you talk about the ER visits. You also talk about patients having to go on disability. There are a lot of folks in the migraine community who are on disability because they cannot work because they're having 25, 30 attacks a month. So for you to say that we're going to reduce or eliminate combination therapy, which was bringing them down to a manageable, number of attacks per month where they could still live a life, they could still work and be productive and be, a lot of these women are in the prime wage earning years of their lives. It's 25 to 45 or 20 to 45, where they are in the sandwich generation, maybe taking care of older parents, raising kids, trying to work. There are a lot of hidden costs that are expended when combination therapy is not provided for and patients can't manage their attack. So Leslie, I would just ask you as a patient, I hear from folks all the time that like migraine patients have been combination patient or therapy patients like their whole experience because every attack is different. You may have something might work for you one day and you have to figure out because of the spectrum nature of the disease what works for you. Had you used therapies in combination together? And can you talk about how, basically this treatment journey means you have to find what works for you?
Absolutely. And part of like one of my triggers is when we get fronts and the weather systems change. And so we've tried the barometric pressure protocols. I've had to use, like since January, I've had to use every rizatriptan or Maxalt that I have because like I'm on day 2 and I've taken 2 yesterday and 2 today, it's still there. And I've done everything preventatively that I can think of. Like sleep is a trigger for me. So I'm very protective over my sleep. I don't go out late anymore. Like I'm home in bed by 9 or 10 o'clock, but there's only so much that I can affect, me being me and a consumer.
Right.
And being compliant with my medication is important. Getting enough
Yes.
rest and the factors I can control. I'm happy to do that. And I do, but I still am experiencing this condition. And frankly, it's very annoying because I get frustrated. I can't be there for my children at times in the way that I need to be there for my children. And it affects my work.
Yeah.
Being able to hear and listen and support the people that I'm working with and concentrate on, like, when you're doing therapy,
You're not in a low trigger job.
Well, no. And when you're
Yes.
doing therapy, it's not a passive thing. It looks passive because I'm sitting there or I'm playing with them, but I'm also thinking ahead, anticipating, analyzing things that are shared with me so I know what direction to go with them. So it's
Yes.
not, it's like an ongoing, you have to be on when you're with that client for an hour
Yes.
at a time. So
Yes.
it's frustrating. And I don't have a lot of patience with it. So
Sure.
it's aggravating.
Well, and it sounds like you're doing your part, but another sort of utilization management barrier that we talked about, step therapy, where insurers might, keep throwing hurdles or obstacles, therapies that you have to fail, even though your prescriber, your provider has already said, this is what you need to get healthy.
Mm-hmm.
In some cases, we mentioned this can take months, but Dr. Nissan, talk to us first about how does this put patients at risk for adverse, and I might add very expensive events. My understanding is that an override request can be granted in Texas, but the clinician has to demonstrate that the preferred drug would cause harm or be ineffective. But talk to us about sort of onerous step therapy and what happens to your patients when they have to face all these hurdles.
Yeah, that's a great question because step therapy is probably one of the worst things that's been done by the pharmacy benefit managers in recent years too. And essentially what's going to happen, if you have a younger woman, for instance, who's childbearing age, working years and everything, and you make them go through, there's a whole sequence of meds. And by the way, most of the patients have already been on them, kind of like what Leslie described. She might have seen multiple different neurologists throughout her life, going from her teenage years all the way into adulthood. And after delivery of babies and things like that. And so what happens is they say, well, this patient has to fail, this anti-epileptic drug plus this antidepressant plus this blood pressure lowering med that we use for migraine, some of the migraine FDA-approved drugs, which some of them should not be used in women of childbearing age. Like they have what we call teratogenicity, which is basically they can cause harm to the fetus and just an accidental pregnancy and stuff. And you just don't know. I mean, some of these patients, it's very frustrating if they've already been on these drugs before and you tell them, hey, you got to be on it again for X amount of months. So if you're going to delay their care for, let's say, 3 to 6 months to say that they failed or had adverse side effects to the other drugs they got to be on, just so they can get on a monoclonal antibody or they can get on Botox or both of them, whatever it is. And so I think what we're seeing is delays in treatment, worsening cases. A lot of these patients wind up in the emergency rooms. I used to do a lot of inpatient work when I was both in Illinois and in Texas. I first moved out of Texas in 2011. I used to work at Baylor in downtown Dallas, and we were admitting patients to the hospital. They were in horrible, unbreakable, voluminous vomiting. They were dehydrated, and they'd have to come in for multiple days in the hospital. And it's quite expensive. You're talking about a $50,000 hospital stay or $100,000 hospital stay. Could have been 100%.
Because they're not well managed.
Yes, it's easily much easier to manage, and that's what I think that is lost in this whole thing is that yes, the cost of balance the cost of healthcare versus benefits, but the fact of the matter is migraine can be a very expensive disease if it's not controlled. And talk about 12% of the population, you're talking over 3 million Texans that have it, and nationwide you're talking 40 plus million, and that's a pretty substantial burden on the healthcare system. So I think that Oh, sorry.
Yeah, I was just going to say, and a lot of those hidden costs are also borne by providers and their clinical practices. So, we haven't talked about prior auth yet, but all of the paperwork burden when folks are denied, the amount of time and resourcing that you have to pay staff. Can you speak a little bit about that in terms of the burden of time and money that you spend on staffing to do paperwork?
Yes, that's a huge component. So luckily in my practice, we have 12 providers. We're a very large group and we can spread out the cost. But for instance, if I was a single provider, like the old days, the guy that puts up the shingle and sets up his or her own practice, I'd be bankrupt right now and I'd never be able to function because we literally have 3 full-time staffers. That's all they do is call insurance companies 8 hours a day, 5 days a week. And they have, the crazy thing some of these insurance companies do is that they'll keep you on hold for an hour and you just can't do that. They'll literally, you got to talk to this person, there's another person, all that. And so you're waiting for all this. And it's all a game of waiting and waiting and waiting. And while you're doing this, the patient is the one that's suffering on it because there's only so much you can do. And it's gotten worse. I'm a member of the Southern Headache Society, which has 17 state chapters. Texas is the largest, of course, in the South, but we're all complaining the same stuff. It's in Florida, it's like this, and Arkansas, Louisiana, New Mexico, everywhere, all the neighboring states here too. And basically, we're saying all complain the same stuff. People are not, doctors' offices can't sustain that kind of financial burden. It costs a lot of money for full-time staff and everything, and the hours are spent, and we're getting tons of denial. Like, it would be great if it was efficient. The problem is we're still getting denials. After you're spending all this money and time and doing everything the insurance companies tell you what to do, you still get denied on the care. So it's like you're wasting all this time and yet you still get denied. So I think it's going to really break the backs of most practices in this country, and it already has. And so I think unless you work for I used to work for Baylor, they had tons of resources. They're a multi-billion-dollar healthcare research. They're one of the largest in the state. And even with them, we were getting denials, and we had a pretty powerful group on there. So I think now in private practice, last 5 years, I'm seeing it's getting even harder. It's gotten worse, substantially worse.
An adjacent issue to that is the fact that neurologists are like the number one most burned out profession. And that's partly because of the shortage of specialists who can treat. So you're just overloaded, obviously, but also due to things like that. So I think that's a point well taken. That's a good segue to maybe our last sort of topic, which is telehealth expansion. There's some states that are putting sort of a legislative thumb on the scale for telehealth at the expense of in-person visits. And there was a GAO report issued, I think earlier or late last month, that talked about whether, for example, CMS ought to look at whether there are poorer health outcomes coming out of this push towards primarily telehealth. And so, for migraine patients, that doctor-patient relationship is so important. And so I guess, we as a community have talked on a policy level about the need for a balanced approach, when folks are thinking about reimbursements and not putting that thumb on the scale for telehealth at the expense of patients not being able to see their providers in person. So I just wanted to hear from both of you, maybe Leslie first, about the importance of seeing your doctor, having a relationship with your doctor, potentially seeing him in person. But, migraine is not a biomarker disease. It's not a cholesterol level that gets checked. It is very much a tracking and, a journey, as we've said. So can you talk a bit about your need to have a relationship with your clinician?
Well, it's vital. I have a different insight because I also provide kind of clinical services on a different level, but you have to have trust in the person that is there to help you, because if you don't, you're not going to maybe tell them all your symptoms or
Sure.
maybe try to make it look better, or I'm trusting this person implicitly to help relieve this pain that's interfering with my ability to work and be a parent and be happy. And I do this. I know what docs are. We've had to do them on the psychiatric side. And I have a real issue with insurance companies dictating course of care over a physician who's gone to training and experience to help people relieve some of these symptoms. And so, most of the time I have a neurological exam too, to make sure that there's no adverse effects, so that there's not something else indicated. It's just, there's nothing is comparable to face in my opinion.
Yeah, agree. Dr. Nissan, do you have some thoughts on that?
Oh yeah, so for migraine is absolutely patient-centered approach. It's very, very important to have a relationship, and it's true. There's no biomarkers. Most of the MRIs are normal. Blood work is normal. Physical exam most of the time is normal too, but it requires a lot more hands-on approach. There's a lot of back and forth between the patient and the clinician. So I think there's a lot more, because they wind up going to emergency situations and things of that nature as the migraines become more frequent and more incapacitating. Yeah. So I think that the telehealth during, it was funny because we had just started telehealth like a month or two before COVID hit. So in January of 2020, then in March, we were forced to, in March of 2020.
Right. You do what you got to do, right?
It was amazing. It was coming. So we were actually prepared, which was unbelievable because we're not prepared for that. But what we found is, especially as we have patients from all over the state, like I cover pretty much south all the way to McAllen and Brownsville and all the way, I cover for El Paso and everywhere else. I mean, pretty much the entire state, even though Dallas is our hub and our center hub. But still, for some of these patients, it was huge to be able to have access to them, telemedicine during this time until everything got back to normal again. And so, yeah, I think it's very vital in certain specialties like this to have access to all.
Sure. I think that, as we see movement in this space, we hope that there'll be some balance preserved. It's sort of like a pendulum that swings fully one way, and then you hope it kind of swings back to a place where patients are really being, or treatment's patient-centered. So I only have one last question. It's for Leslie, and then we'll jump into any sort of Q&A. If folks have questions, please put them in the chat box. Leslie, I guess to close, I always want to close on a patient-centered level, which is, what does it mean personally to you to be able to find a treatment that works, be stable, and manage your disease? You've got 3 daughters. You work with teens in crisis. As I mentioned, anyone on this Zoom, you perhaps have a lot on your plate in terms of the folks who you're responsible for and taking care of. And so talk to us about what the impact of effective treatment means for you and your family. What does it mean to be able to be on a medicine that works for you?
Basically to function. That's like very succinct, but like before I even started down this journey, there were days where I would have to go to bed and lay down because the headache was too bad, and not being there for my children. And they only have one surviving parent now. So it is even more important that I'm there for them when they need something. But in doing so, I'm also the only breadwinner for financially supporting our family. And
Right.
so it's got far reaching implications, I'm sorry, for my ability to just adult in a way.
Correct. Yes.
And
There's
to
a
be
lot-
happy. Yeah.
yeah.
And it's hard enough like to find joy these days in life.
Yeah.
This crazy world we're living in, but to just enjoy or be at peace and enjoy my family and my friends. That is the biggest thing, is controlling this, because it is definitely impacting.
Yes. I think we all in 2022 recognize and don't take for granted stability. Stability is wonderful in this current environment, but especially for your disease state, for migraine.
Well, and frankly, I don't have enough hours in my day. I'm sorry to interrupt, but I don't have enough hours in my day to call and follow up and chase insurance down and get pre-op. And
yes,
like, if I don't see people, I don't get paid. I don't get a salary. I'm paid by the clients that I see. So if I'm not working, like, when am I going to do all of this? So it's just frustrating.
Yes. This is a question that came in for Dr. Nissan. There are only 41 of the UCNS specialists in Texas. What can policymakers do to be more supportive of ensuring that number either grows, or that headache specialists in the state can be supported?
That's a great question. You know, we look at it. So we had a headache fellowship at Baylor, and there's one at UT Southwestern Dallas. There's one at Scott and White in Temple, so Central Texas. There's 3, and no one can fill. I mean, there's really not a lot of interest. And a lot of it, I think, is the frustration of neurology residents. They're like, why am I going to go into this? There's only 730 of you nationwide. There's 41 in Texas, and we're short. There's a major shortage of it. But I think it's because of these frustrations that they see it. Even when we have students rotating, or residents and fellows and things like that, you know, there's a lot of, it's going to be hard. Because I think until we solve the access issue, I think that lawmakers really have to help us from the insurance side and ease the burden on our offices. Until that happens, it can be very hard to convince, a future 25 or 26-year-old medical student that, hey, not only is neurology great, but man, headache can be a life-changing profession for you. You can really, it's not glamorous. It's not you don't make a lot of money, but you can actually make a big difference in people's world. And I think you'd have a lot more interest in it. I just think that it would be, that's what needs to be changed. I mean, it's really you got to help our offices. Period. It's got to be insurance. We need help with insurance. We need to have strength, because right now I feel we're just pawns in a system where all we're doing, we're not being doctors, we're not being professionals, we're just sitting there checking boxes for an insurance company and hoping to God they're going to cover this stuff. And you're not going to keep fighting and waiting months and months till there's more failures in the treatment and stuff. So
exactly to your point, Dr. Nissan, at this year's Capitol Hill Policy Forum, I was talking with another provider, and they said for years, headache specialty as a practice was not viewed as something where you could help treat your patients, because there were a lack of treatment options. There was very little that providers could do for their patients. And then now all of a sudden we're in an environment where it's exciting. There are many ways to treat and help folks. And so, having barriers crop up, that has an effect that pushes down that excitement in terms of, whether there will be new folks coming into the space and joining the practice of being a headache specialist. So I think that's definitely what I've heard as well. Leslie, you have been a patient advocate. Here's a question. Are there resources and this will be our last question because we're running close to time. Are there resources for patients affected by non-medical switching or prior auth, or what message would you give to patients about dealing with some of these utilization management problems?
There's no resources or advocacy groups that I have found, and I haven't had the time to really search for them. I have the benefit of working in this field and dealing with insurance, so I have a little bit of an insider's perspective and I can kind of approach it from my work experience. But to my knowledge, there's not, and I don't spend like time on social media. I know there's a lot of like treatment group focus people
Yes.
just get on and discuss courses of treatment. I don't even really get on social media a lot just because I don't have the time.
Right. Who has the time for that? Well, with that in mind, I want to close because we're coming to time. I want to first thank our panelists, Leslie and Dr. Nissan. You're wonderful today. I think you really provided that real world perspective that lawmakers and their staff were interested in hearing. Also want to thank our co-host, AFPA. A big thank you to the policymakers and the staff who joined us today because you're doing the work. It gives the migraine community great hope that there are problem solvers who are working to help improve access and treatment. And I would just say, if we can ever be a resource for that work, we stand ready. I've spoken and mentioned to Leslie and Dr. Nissan. They are happy to answer additional questions or provide their perspective. So with that, we'll close today's webinar. We appreciate everyone's time and have a wonderful Friday weekend. Happy Mother's Day. And we'll close there. Thank you, everyone.
Thank you.